This podcast is a production of Open Pediatrics, an open access online community of healthcare professionals sharing best practices from around the world. Visit openpediatrics.org for more.
Hello and welcome to the Open Pediatrics World Shared Practice Forum podcast. My name is Tracy Walbrink and I'm a pediatric intensivist at Boston Children's Hospital and co-director of Open Pediatrics. It is my pleasure today to be joined by Drs. Chanu Rhee and Fran Balamuth. Dr. Chanu Rhee is an associate professor of population medicine at Harvard Medical School and director of the Center for Sepsis Epidemiology and Prevention Studies at the Harvard Pilgrim Healthcare Institute. Dr. Fran Balamuth is professor of pediatrics at the Perelman School of Medicine at the University of Pennsylvania and is also the division chief in pediatric emergency medicine at the Children's Hospital of Philadelphia. Drs. Rhee and Balamuth are the first authors of the study published in the Journal of the American Medical Association in March 2026, entitled National Estimates of Pediatric Sepsis in U.S. Hospitals Using Clinical Data. Welcome to both of you.
Great. Thanks so much for having us.
Yes, appreciate the invitation.
All right. Well, Fran, if I could start with you, I was hoping that you might be able to let us know kind of what the objectives of the study was. What questions were you trying to answer? What methodology or approach did you utilize to answer this question?
Yeah, no, thanks for that. I think, epidemiologic estimates in sepsis have been challenging for a long time, largely because they have relied historically on ICD or diagnostic codes that we know are imperfect, and can be subject to bias, kind of coding level bias. And so there's been interest led and a charge led largely by Chanu and his team, honestly. And about 10 years ago in adults, they did a study where they used electronic health record data to identify sepsis in kind of a more clinically meaningful way. So using the granularity of electronic health record data to identify infection with organ dysfunction in the hospital record. And so I think we are trying to adapt that approach to make it more appropriate for pediatrics in order to get a diagnostic code agnostic surveillance definition of sepsis in kids.
Yeah, just to add to that, since Fran, you added some nice history there. I think we did kick this off really focusing on adults. You mentioned that 2017 JAMA paper where we had basically adapted the sepsis 3 adult definition into a clinical surveillance definition optimized for wide scale EHR based surveillance. And just for a little bit of history, I think that study, of course, was funded by the CDC. And I think there was a really immediate interest, after that study in doing something similar in pediatrics. In fact, Fran, if you remember, back around 2018, 2019, we had meetings at CDC. We had a lot of stakeholders there. We even published a white paper in pediatrics back in 2019, sort of outlining what we thought the path forward would look like in terms of doing something similar for pediatrics. Then, of course, the COVID pandemic hit. Everything got derailed. Certainly, our colleagues at CDC got very distracted, to say the least. But we were thrilled, I think, sort of as the pandemic began to recede. Then back in 2023, when CDC was able to sort of resurrect this idea, and Fran and I and Scott Weiss and Mike Klompas, sort of as the leads for this study, were able to sort of reconvene a coalition to take on this work. And I think the timing worked out really nicely because I think one of the biggest challenges, back in 2018, 2019, when we were thinking about this for pediatrics was, what would be the reference standard? We ideally you tie it back to sort of a consensus clinical definition, which at that time was really just based on the 2005 pediatric sepsis definition. But even at that time, I think it was pretty clear that that was, kind of out of date, especially with the advent of sepsis 3. So, back to our current study, I think the timing worked out perfectly. We knew that the Phoenix criteria were sort of, being developed. We actually partnered, obviously, Fran and Scott Weiss were part of that task force. We partnered with other leaders on the Phoenix task force. So we sort of had a head start and we were able to, coordinate that timing to develop a surveillance definition that was really, based on the Phoenix concept, but adapted for routine wide scale EHR surveillance.
That's excellent. And I wonder if you wouldn't mind going into the definition, the pediatric sepsis event definition, and how you chose that. What sort of assumptions did you have to make as you began to modify this from the Phoenix guidelines?
Yeah, great question. So I can start, and then Chanu, feel free to to chime in, but I think we use the framework, the same framework that Chanu and his colleagues had used in adults, but kind of adapted it for Phoenix as opposed to for SOFA, which is where the adult definition was based. We convened an expert panel, so many of the players that were present at that CDC meeting in 2018, 2019 kind of came back into the fray, as well as some of the folks from the Phoenix task force, kind of sepsis experts from around the country and around the world, to kind of come together and look through the categories of organ dysfunction in Phoenix and decide, which components of that did we think were feasible to obtain from the electronic record, and which ones could we do we think we needed to adapt. And so we did a couple of iterative rounds with that group, and then came up with kind of a candidate definition.
Yeah, exactly. And just building on that, I think sort of one, question, folks might have off the bat is, well, why not just use the Phoenix definition? I mean, the Phoenix task force, operationalized the definition using large data sets. So why not use that? And I think what we would point out is that obviously the Phoenix sepsis criteria were a major conceptual advance, but they weren't really optimized for sort of population level surveillance or epidemiological estimates. And their primary goal was to develop basically a sort of a new organ dysfunction score that was optimized for children with suspected infection. And so, the way that they developed it was basically they use a very broad definition of suspected infection. Like they use like any microbiology test plus any antibiotic within 24-hour window. And so, makes total sense for what they were trying to do. But for our purposes, when we were really looking at retrospective population surveillance, we want to not just capture those all the children who were initially treated for possible infection, but really want to try to hone in on patients who, in retrospect, probably did actually have infection and true associated organ dysfunction. So that was sort of one important adaptation in thinking about sort of how do you define infection. And then when it comes to the actual organ dysfunction, again, Phoenix, they leverage very rich, data sets to develop their score. But several components within Phoenix are challenging. And for anyone who works with EHR data and these type of analyses can sort of probably appreciate that it's never quite as simple as it seems to implement some of these rules and these parameters. So, for example, ventilator parameters, so things like P to F ratios or S to F ratios, sounds great in theory. When it actually comes down to operationalize these and do it at scale in a way that's consistent across hospitals, there's so many nuances that go into it, ranging from the completeness of the data, how have you tied together the timing of a P and an F values. That was pretty clear that that was something that would have to be adapted and simplified. And similarly, one of the criteria in the Phoenix definition is fixed pupils, and I think clinically a very important parameter, but not routinely captured in electronic health record data. So those are some of the considerations we had when adapting the Phoenix definition. So, I don't know if we want to go into all the details, but essentially, sort of the pediatric sepsis event definition really hones in more on blood cultures being drawn as the anchor rather than any microbiological tests, a little bit more specific for sepsis. And then it hones in on patients who got at least 4 consecutive days of antibiotics to hone in on those. Again, not just started initially empirically on antibiotics, which is nowadays like almost anybody, but sort of where the clinicians actually had sustained concern for infection. And then the organ dysfunction again was adapted very closely from Phoenix. They said the biggest adaptations were around the respiratory failure criteria, where we basically streamlined it to invasive or non-invasive ventilation, and then we also had to simplify the GCS. I'm sorry, the neurological criteria, where that fixed people really just wasn't a feasible component for this type of definition. And the GCS as well was also a challenge because we also know that capture of GCS is very incomplete across hospitals. And so we also, in data sets where GCS was missing, we actually use ICD codes for neurological dysfunction. So those are some of the practical adaptations we made to optimize it for wide scale application.
That's great. And, I really appreciate all those considerations as you went into the definition. I also serve as program director for our critical care fellowship. And so I always like to think about, how do you even get started on these kinds of research studies? What are all the components into that that go into it? And so you've obviously spent a lot of time creating the definition. And I'm curious, the next step obviously is the validation of, this definition. I'm curious if you could walk us through a little bit of that, any lessons that you learned there, anything that didn't work from the original definition that you had to modify before you started, exploring this in the full study.
Yeah, great. So I can start with that too, and then again, Chanu, feel free to chime in. But we chose to validate the study at three sites, all of whom had active sepsis quality improvement programs, and so we took advantage of the fact that they all participated in a collaborative called the IPSO Improving Pediatric Sepsis Outcomes Collaborative that submitted patients with infection, essentially who are admitted to the hospital. So it was kind of an enriched group of patients with infection where the risk of sepsis was higher than we took all comers in the hospital. And so we sampled from that group of patients, and each hospital did around 200 chart reviews of patients, a mixture of patients that kind of met the IPSO sepsis criteria, and then patients who had infections and were admitted to the hospital but didn't have sepsis. And we applied the candidate definition to that, and then did test characteristics and looked at the patients where there were mismatches to try to figure out, are they mismatched in a way that we could improve the definition moving forward. And so that's how we did the validation.
Yeah, yeah, and just add a little bit to that. I think so chart reviews are always time consuming, and anytime you're trying to adjudicate the presence of sepsis, I think you always run into some challenges. The reviewers have to decide whether there was credible evidence of infection in retrospect, whether there's organ dysfunction at the specified thresholds, and then whether that organ dysfunction was potentially related to infection. So that's sort of how we operationalize sort of the reference standard by which we calculated against which we calculated sensitivity and specificity and positive and negative predictive value. Basically, we took the concept of Phoenix and said, we want the reviewers at each of the sites to review these charts in great detail and decide exactly that. Was there a plausible infection? And was there organ dysfunction at the threshold specified by Phoenix that were potentially related to infection? So that was sort of our reference standard, and again, basically simply calculated performance characteristics. So how long did that process take, Fran? I mean, we ended up doing almost 600, basically about 200 reviews at each of the sites. So it was a multi-month process, and we spent a lot of time, as you can imagine, sort of creating obviously the standardized abstraction tool in REDCap, doing some training at each of the sites to just make sure everybody was on the same page about how we're going to approach these adjudications, how we're going to adjudicate possible, probable, definite infection and sepsis. And so always a little bit of a squishy target, but we definitely had some experience, quite a bit of experience doing similar type of validation exercise in the past, so we were able to leverage that and build on that.
Perfect. So you went in and defined pediatric sepsis events. You then validated, and now you're into your study. I was hoping maybe, Chanu, if you could walk us through the results, what you found. What are the salient findings from your work?
Sure. Yeah. So I think maybe the top line statistic, which is a national burden, the estimated national burden of sepsis and deaths. So when we projected, the findings from the primary data sets nationally, we estimated over 18,000 pediatric sepsis cases annually, and over 1,800 associated deaths over that 2016 to 2022 time period. They were basically unchanged. So, after we developed and validated the pediatric sepsis event definition, we applied it to multiple large data sets with the goal of estimating sepsis incidence, mortality, characteristics, and trends over time. And I will say, our primary data sets that we use for our national epidemiological estimates were drawn from Epic Cosmos, which is a enormous data set from healthcare systems that use Epic, the Epic EHR, and sort of contribute to this, centralized data warehouse, or sorry, database. And we also complemented that with data from the HCA Healthcare network, which is the largest private inpatient healthcare system in the country. And those were two non-overlapping data sets. And so basically that between the study years of 2016 and 2023, that gave us a cohort of about 3.9 million non-neonatal pediatric hospitalizations. And then we applied the PSC definition there. And to jump to the main findings, I would say the first was in terms of incidence. So basically, about 1 in 75 non-neonatal pediatric hospitalizations involve sepsis. And, I think although that incidence may not sound enormous at first glance, I think the associated mortality burden was quite striking. So about 1 in 10 children with sepsis died during their hospitalization. And sort of when looking at that entire 3.9 million patient cohort or hospitalization cohort, nearly 1 in 5 of all in-hospital deaths involved sepsis. So that was kind of some of the striking findings just on the burden there. I think another thing I would highlight was that we the advantage of this definition of the electronic definition is you can get a lot of granularity into the timing of sepsis onset. So where the criteria met sort of within the first 2 days, and then we classified that as community onset, or if they're met sort of on day 3 or later, then that's hospital onset. And what we found was that um, about a quarter, actually more than a quarter of cases were hospital onset. I think that's something. I'm also an infection control person, so I really, a striking finding to me because I think it suggests that there may be some meaningful opportunities for prevention and quality improvement within hospitals. And I think the third major thing I would highlight is the trends over time. And so we looked at trends sort of within the hospital cohort, and then we also projected it. We projected all these findings nationally, and we found that the sepsis incidence and associated mortality remained largely unchanged from 2016 through 2022. And to me, that was bit striking. We know there's been a lot of awareness and increasing emphasis on early sepsis recognition and treatment, and I think it really emphasizes that we still have a long ways to go.
I think another just a couple of things to highlight about it about the use of the data sets that we used is that I do think one difference I think between adults and pediatric care across the country is that pediatric critical care doesn't exist at every hospital, right? So you guys are exist largely in specialized centers, which is where most of sepsis will end up, but it's not always where sepsis starts. And then there are some sepsis cases that will get cared for in the community. So an advantage I think of both the Cosmos and the HCA data sets is that they include kind of community hospital settings where often some pediatric research has struggled to find data from in the past. So I think that's an advantage of this. And then I guess the other thing just to call out again, which Chanu did say, but that just to underscore that neonates were not included in this study. So we know that there is a large burden of infection in young infants, and this, but that kind of both the biology and also the way that sepsis is conceptualized in kind of the NICU or newly born population is a little bit different from this. And so I think the consensus back in 2018, when we kind of convened that um, discussion group at the CDC, was that neonatal sepsis would be kind of in a different bucket. So I think there hopefully will be future efforts in the neonatal space. And I guess just to add on top of that, so that number 18,000 is a smaller number than have been presented in other pediatric sepsis epidemiologic estimates in the past. And I think kind of our interpretation of that is that Phoenix definitely identifies a quite ill population, right? The Phoenix organ dysfunction criteria were modeled based on mortality as the outcome. So these are children who are at the highest risk of death, and so I think it shows just kind of how far Phoenix has moved the needle on the illness spectrum, that we really are talking the patients in this paper, like we really are talking about quite a sick population.
That's great. And Fran, I wanted to go back to one thing that you mentioned, with the inclusion of community hospitals, and obviously sepsis is a global disease that affects lots of children around the world, and we know less about incidents in low and middle income countries. And I'm curious. Any lessons learned from trying to do this national estimates that you think could potentially be applicable to those that might be wanting to do this type of research in low and middle income countries? I don't know if you talked about that at all as a group, or any considerations with that.
Yeah, no, it's a great question. I mean, I think so the Phoenix data sets that were used to develop Phoenix did have data from low and middle income countries, at least some of it. And I think certainly strategy, requires an electronic health record. So I think it would be tricky to do it in the absence of that. Although certainly, I think there are plenty of countries that have access to EHRs. I think the reason we did not include other countries in this study was kind of practical, based on it was funded by CDC. It was really kind of looking to develop a surveillance definition in the United States. But Chanu, I don't know if you want to add anything else.
No, no, exactly. I mean, I think I like to think that other countries could learn from this, but I would certainly acknowledge that I think in low middle income countries where if you don't have an EHR or a robust EHR system, obviously it's not really going to be feasible. But as Fran said, plenty of countries that do, and again, I hope that some of these lessons could be adapted in other countries as well.
Excellent. I'm curious just to kind of move into some of the limitations of the study that you identified, and sort of describing a little bit of those in more detail.
Sure, sure. There are multiple limitations as with any study. I guess Fran, I think already mentioned sort of the fact that we didn't focus on the neonates. So I think we can't emphasize that enough. Very important population, but very different population that really needs their own surveillance criteria. I think sort of from a measurement standpoint, I think you know we are big believers that EHR based surveillance sort of takes us forward. It's a step up from code diagnostic code based surveillance, but I think it's important to also be realistic and acknowledge that it has limitations. It's not perfect. There's no perfect way of identifying sepsis, and this method is no different. And in particular, misclassification or imperfect sensitivity, is certainly possible. And so where are some areas where the pediatric sepsis event definition sort of can miss? I think the most we analyze this when looking at sort of the quote unquote false positives and the false negatives in the chart review validation cohort. And I think one common cause for missing sepsis cases were patients who actually did have infection and associated organ dysfunction, but didn't meet that 4-day antibiotic threshold. And so I think we saw a number of those that were probably related to severe viral infections. Now we do include antivirals in the definition of qualifying antimicrobials, but obviously things like RSV, they don't have targeted antivirals. So that's one scenario where we can miss true viral sepsis. And I think conversely, in terms of thinking about false positives, I think the two biggest areas are, well, a patient can have a blood culture drawn, they can get 4 more days of antibiotics, they can have organ dysfunction, but actually, when the dust is really settled and you look close at the case, the patient really didn't actually have infection. They were just being treated still empirically because the team was very worried about the patient being very sick. So that certainly happens, or the organ dysfunction that was flagged, was more clearly related to some other cause. Maybe they were intubated for a procedure, for example, or all the other things that can contribute to organ dysfunction in hospitalized patients. So again, and overall, it performed well. It actually performed very consistently with how the adult sepsis event definition did, but important to acknowledge those, the potential for misclassification in the definition.
And I think, one thing that was clear from the chart reviews, and I think maybe a partial explanation as to why we haven't moved the mortality rate in the country, is just kind of how complex some of these patients are. So, certainly another limitation, I guess, is that the validation was done at 3 academic centers, right? So we could have been enriched for more complex patients. But I do think that, as we think about the kinds of patients that are coming to, academic centers over the last decade, certainly the complexity has gone up, right? CAR T cells, there are many things that kind of cause multi-system organ dysfunction that can be difficult to interpret. Is that kind of chronic organ dysfunction? Is that associated with infection? And so I think that does kind of add to the complexity, also probably adds to the mortality risk. And so that may be another reason why the mortality has not moved.
Yeah, sort of building on that. I mean, this was primarily obviously a large surveillance and epidemiological study, and so I think the trends that we found were, really really fascinating. But I think we're ultimately left to sort of, speculate a little bit on why incidence and outcomes have remained, relatively stagnant, and certainly we didn't dive into things around, you know, um, adherence to protocols or bundles and sort of outcomes. So we weren't able to dive to that level.
That's great. And I think that sort of, puts me into the next question, which are, what are the next steps for you and your co investigators? What do you hope to do following up on this study?
So I think, on a practical level, I think one of the big goals of this study was to develop kind of surveillance tools that other hospitals could use could use locally. So part of what we developed with this was a toolkit that hospitals could use to develop their own surveillance system, kind of most easily adapted with Epic, if you have Epic, because that's the kind of coding was written largely with Epic as the most common EHR. But I do think this will allow hospitals potentially to track outcomes of patients better, even with sepsis quality improvement initiatives. So some of what Chanu said in the beginning around, most hospitals will track kind of antibiotic timeliness, fluid timeliness, bundle compliance in this kind of suspected sepsis population. But then if we want to look for outcomes, we really care about what happens to the ones who truly had it. And so this is a way where hospitals could say, okay, we're going to track our kind of, timeliness metrics in a broader population. But when we're looking at outcomes, we could implement this kind of more stringent surveillance definition that might help us to see, if our strategies are working in a more effective way.
Yes, I think I would certainly hope and that hospitals will, begin to, incorporate, pediatric sepsis event surveillance. I think sort of from a research standpoint, I know Fran, has lots of ideas as well, but, for me, yeah, I think potential next steps would be using this framework to better understand variation, in, pediatric sepsis, epidemiology and outcomes across different populations and hospital settings. I think that would be, very interesting. I mentioned before the hospital onset sepsis angle, and again, the how sort of striking that, over a quarter of cases appear to be hospital onset sepsis, as you'd expect. They're associated with higher crude mortality, and so I think, and because it's happening, obviously, once they're under the care of a hospital, I think we have a particular responsibility to try to prevent as many of those as we can. So I think that's a really important and underexplored area for future investigation. And lastly, I would just highlight one other thing, which I think, I'm very excited that, certainly in adults, we are moving more towards sort of outcome, sort of a focus on outcomes in sepsis. So what I mean by that is, in adults, we've had the national focus around sepsis quality and policy has really been around process, particularly through the SEP1 bundle. And that's been around since 2015. And, I've certainly sort of been a critic of SEP1. I'll acknowledge it up front, but I think what I would say is that, certainly done a lot of good. It's raised a lot of attention. I think a lot of stuff, similar stuff has happened in the pediatrics world, a lot of focus on early recognition and treatment. Um, but what I'd love to see is the field go more towards outcome-based measurement so that, yes, of course, the early bundles are important, but, I think sort of having a robust risk-adjusted outcome measure can really shed light into which hospitals are actually doing well overall, maybe beyond just the bundles, but sort of through comprehensive care throughout a patient's hospitalization. Which ones might be doing a little bit worse, and sort of are can we target for more attention to sort of improve on their practices. And in adults, we are we've been collaborating with the CDC and CMS. There's interest in developing a risk-adjusted mortality measure. Obviously, we're a bit behind on children now. We just came up with this pediatric sepsis event definition. But long story short, I would love to see more work in that space begin to move towards a pediatric sepsis mortality measure.
That's excellent. I'm curious if there was anything from the study that really surprised you. Any findings or anything that was, unexpected or different than you had planned?
I'm trying to remember, Fran, our group's reaction when we saw the trends over time. I mean, I think maybe I would say probably many of us were hoping to see a bit more of a decline in mortality rates, and so I'm not necessarily I would say I'm surprised because we saw something similar when we did our adult burden study where we saw that incidence and mortality were largely flat. So, but I think that's was one thing where again maybe we were hoping to see more encouraging signs and we didn't.
Yeah, and I think maybe this is not surprise, but just kind of underscoring again, the mortality rate in Phoenix sepsis is really kind of a little bit different, I think, than what's been conceptualized in prior definitions of sepsis. And so, thinking about that and what the impact of that will be, moving forward, right? Like, there certainly are sick children who have degrees of organ dysfunction that don't meet Phoenix criteria, and does that mean do those patients, I mean, yeah, kind of do we need to think about those patients in a different way? I think will be interesting moving forward.
Any other lessons that you have, lessons learned for our community, to take away from our findings that you haven't already mentioned, or anything that we haven't talked about that you want to make sure gets discussed here?
I mean, I feel like I say this in every sepsis study I work on, but I feel like sepsis is such a team sport that I think having such a varied team, like I think Scott Weiss, I think from Pete's Critical Care, and then having Chanu and Mike from the adult world who'd had the kind of the original lens, and then all the people who contributed to both kind of the candidate definition, the chart reviews, and then all of the EHR kind of coding work on the back end really does, sepsis is a complex phenomenon that I think takes a big team clinically in the hospital at the bedside to take care of the patient. And I think studying it because of that complexity is also takes a big team. And it was cool to see all of that come together.
That's a great comment, Fran. And I'll just add, maybe just take this chance to emphasize again, why that measurement really matters. And I think just emphasizing again, if we really want to improve sepsis outcomes at a population level, we really need reliable and standardized ways to track the problem, so we can understand if our interventions are really moving the needle, what's working and what's not working. And again, our study, our method is not perfect, but we think this hopefully takes us to a better spot than we were before.
That's great. I think both of those are really important items. So I appreciate you sharing those. Um, and I'm curious if you have any tips, again, going back to trainees, junior faculty, for those that might be interested in this kind of research. Any advice that you might have for people to kind of get started, or tips or strategies for success?
Yeah, I mean, I think doing research on like on data that exists already is often a nice place to start for someone who's kind of tipping their toe into research, and that you don't have to prospectively collect data over a period of time. It certainly has its own levels of complexity. It's never as easy as it seems like it's going to be from the start. But I do think that finding good mentorship is always key, and I do think that there are these kind of increasingly rich data sets and tools to handle big data where we can learn a lot. So I think there is a ton of possibility kind of in this EHR data space as we move forward.
Yeah, and I totally agree. And maybe I would add, just, I encourage my mentees. So first of all, choosing a good mentor, absolutely. And then I think choosing a good question is obviously really critical, and not being afraid to look at things that maybe are thought to be settled science. If you have an interesting sort of angle or an interesting hypothesis, I think I would encourage, trainees to, obviously in consultation with the mentors, but not to be afraid to take on questions that are potentially controversial, or again, that sort of go against the common thinking. And if I could use that to just mention, when I first started this line of research around surveillance, I mean, it took some time to get off the ground. We had some pretty bad rejections from some of the journals that some of our initial studies. And I think part of it, in reflecting on that, I think it's because sort of went against the common wisdom of the time. There were all the studies were sort of based on ICD codes and sort of talking about this ginormous ballooning of sepsis incidence over time, but also sort of dramatic declines in sepsis mortality rates over time. And sort of I was sort of coming at the angle with that, some of that or a lot of that might be ascertainment bias, and we need to sort of think about more, rigorous and objective surveillance methods. And again, I'll say, it was not very well received at some of the, some of the journals when we first submitted it. But yeah, I'm certainly glad I persevered on that, and it's sort of led to, I think, for me, a very rewarding, body of work over the past decade and more. So
Well, that's great. I think, you're both describing, finding something that you're passionate about, finding good mentors, sticking with it, one foot in front of the other every single day to kind of build this career. And I really appreciate both of you taking the time today to come and talk with me and share your experiences, share the findings from this study, and some really important tips for getting started, as well as for mentorship. So thank you both for participating in this podcast and being our guest speakers today.
Thanks so much for having us.
yeah, thanks so much for having us.
This has been a production of Open Pediatrics. You can find the resources and journal articles referenced in this podcast in the description. We have more podcasts like this one available everywhere you get your podcasts. Visit openpediatrics.org for more information.